Dr. Asmaa Mgdy. Her presentation will be about recent advances in imaging of cancer cervix.
Hi, everyone. I'd like to thank the chairpersons and the attendants and the organizers of this conference committee. I'm Asmaa Mgdy, Associate Professor of Radiodiagnosis in Shams University. I'm talking about recent advances in imaging of cervical cancer. Small introduction, the Figo classification, and then recent imaging modalities like MRI, PET-CT, and PET-MRI, and then conclusion. Cervical cancer is the fourth most common cancer among women, representing 13% of gynecological malignancy. The most important predisposing factors for cervical cancer are human papillomavirus, immunodeficiency, smoking, socioeconomic factors, lower income levels, and less access to screening tests, and human papillomavirus vaccination and family history. The prognosis is based on the stage, size, and histologic grade of the primary tumor and the status of lymph nodes. Assessment of the stage of disease is important in determining whether the patient may benefit from surgery or will receive radiation therapy. Imaging techniques like MRI, ET, FDG, PET-CT has gained importance in recent years in initial staging, treatment, and monitoring of cervical cancer, and follow-up after surgery. The Figo Staging system is used for planning treatment strategies and the prognostic classification of patients with cervical cancer. As we see here in stage 1, where the cancer is confined to the cervix or less than 2 centimeters, the patient has better prognosis and are eligible for fertility-preserving surgery, where the surgery is removing only the cervix and the upper vagina and the surrounding fat. Small tumors less than 4 centimeters are confined to the cervix, treated with radical hysterectomy and bilateral salpingioophorectomy, whereas tumors more than 4 centimeters and other stages are treated with concurrent chemoradiotherapy. In modified Figo 2018, introduction of the lymph node as stage 3C is introduced. The pelvic nodes is 3C1 and the para-aortic nodes 3C2. In patients with early stage cervical cancer 1A and part of 1P1, the microinvasion is only detectable using tissue evaluation. The rest of the tumor stages, including local extension, can be assessed using imaging modalities such as CT, MRI, PET-CT, or PET-MRI. The National Comprehensive Cancer Network 2022 Oncology recommended PET-CT for tumor surveillance and follow-up, and the MRI for the local assessment of stage more than 1P1. In MRI, the high soft tissue contrast resolution of MRI makes it the preferred modality in local staging of cervical cancer. The main role is to assess the tumor size, parametrial invasion, pelvic side wall extension, and the invasion to the adjacent organs like bladder and rectum. The use of IV contrast material in evaluation of cervical cancer is controversial. Many authors don't recommend routine administration of IV contrast, which is good in our era where the IV contrast is unavailable in many centers. However, dynamic contrast enhanced MRI is reported to be of value in small lesions for surgical planning in patients who wish to undergo fertility-sparing surgery and to distinguish between cervical and endometrial tumor where primary tumor is locally extensive. Adding diffusion improves the identification of residual and recurrent tumor compared to post-radiotherapy changes. The normal cervix in MRI in premenopausal women, as we see here, the mucosa is high signal intensity in this dotted line. The fibromuscular stroma shows low signal intensity in this dashed line, and the cervical stroma is intermediate. In postmenopausal women, the mucosa becomes very thin, and the cervical stroma becomes uniformly hypointense. The tumor is best seen in T2 weighted image, in which it appears as expansile and infiltrated mass with increased signal intensity compared to the low signal cervical mucosa. The parametrium is the fat and connective tissue surrounding the cervix and uterus. As we see here in this cervical cancer, the mass is show low intermediate signal intensity, and it doesn't invade the cervical stroma all around in the 3 planes, axial, coronal, and sagittal, so there is no parametrial invasion. Parametrial invasion is disruption of the stromal ring on the obliteration of the periuterine fat planes. Adding diffusion increases sensitivity and specificity of MRI. As we see here in this image, the cervical cancers, there is left parametrial invasion with disruption of the low signal intensity rim of the stroma. Also, it shows high signal in diffusion and low signal in EDC. The pelvic side walls are the muscles like the piriformis, obturator internus, and levator ani, and the internal iliac vessels. Pelvic side wall invasion has been described as tumor that is less than 3 millimeter from the pelvic muscles and vessels. As we see here, the tumor here invades the left parametrium, and the distance between the tumor and the left levator ani is less than 3 millimeter. Also, it obstructs and invades the ureter with subsequent left hydroureter. Extension to the vagina. It is seen as replacement of the low signal intensity vaginal wall by high signal intensity tumor. Introducing into vaginal gel deposits the normal vagina here. We see the anterior fornix and the posterior fornix. Here the mass of the cervix is extending to the upper part of the vagina with replacement of the signal intensity of the vagina here. Also, here the cervical mass invades the upper 2/3 of the vagina. Bladder invasion. The MRI findings that suggest bladder invasion include nodular and irregular bladder wall, tumor protruding in the bladder lumen, and high signal intensity of the anterior aspect of the posterior wall of the bladder on T2 weighted image. Presence of vesicovaginal fistula is diagnostic for bladder wall invasion. Rectal invasion is less prevalent than bladder invasion in patients with stage 4 disease and carries worse prognosis. As we see here, the cervical mass invades the bladder and the rectum. Lymph node invasion. MRI findings that predict metastatic involvement of lymph nodes are larger than 1 centimeter in short axis, being lobulated or speculated contour. Its signal intensity is similar to the primary tumor. Using of the fusion for lymph node staging has been controversial. Some studies that it has no role, and some studies that it can differentiate metastatic from benign lymph nodes. Indications of MRI is in local staging, pre-treatment, and local advanced tumor. Mid-treatment MRI after 5 weeks of concurrent radiochemotherapy before brachytherapy dose to adjust the dose in proportion to the residual tumor volume. Follow-up after finishing of chemoradiotherapy and follow-up after surgery. Follow-up after chemoradiotherapy, the MRI can detect the decrease in the tumor size and reconstitution of the normal low signal intensity of the cervical stroma on T2 weighted image. Also, adding diffusion is a useful tool to differentiate recurrence from treatment response where the tumor recurrence shows diffusion restriction. As we see here in this case, the cervical cancer extended to the upper part of the vagina. Also, it shows diffusion restrictions. It shows left parametrial invasion and encroaching upon the anterior wall of the rectum. After chemoradiotherapy, the cervical mass disappears, retaining the normal mucosa of the cervix, low signal intensity. Also, in diffusion, there is no diffusion restriction, no parametrial invasion, representing complete response. In this case, the cervical cancers invade the upper part of the vagina, and it shows parametrial invasion in diffusion. After chemoradiotherapy, the mass decreases by 30%. It also shows parametrial invasion and diffusion restriction, representing partial response. In this case, the cancer cervix invades the upper 2/3 of the vagina. Also, there is parametrial invasion and diffusion restriction. After chemoradiotherapy, the mass is the same size and the same parametrial invasion and diffusion restriction, representing stationary course. In this case, the cancer cervix invades the uterus and the upper part of the vagina. Also, it shows parametrial invasion and diffusion restriction. After chemoradiotherapy, it shows progression and it extends to the urinary bladder anteriorly and the rectum posteriorly, representing progression of the disease. PET-CT. PET-CT is a non-invasive imaging method combining the morphological finding provided by CT with metabolic information. To acquire information, the patient is injected with glucose analog fluorodeoxyglucose that is labeled with positron emitter. Areas with high uptake correspond to sites with high glucose metabolism, such as inflamed tissue or tumor cells. It is a useful imaging method in assessment of lymph node and distant metastases in patients with local advanced cervical cancer and for assessing response of treatment and disease recurrence. Most cervical tumors are 18 FDG avid, with exception to adenocarcinoma, which may reveal low FDG uptake. The maximum sensitized uptake value SUV max is currently the most commonly used parameter in PET-CT. The international guidelines for 18 FDG PET-CT imaging in cancer cervix, it is used in initial staging, and it is recommended for local advanced cancer if nodal metastasis is suspected. Also, it is used in treatment response assessment. If the first post-treatment FDG is indeterminate, then another one is done after 3 months. In surveillance and recurrence, it is used in follow-up visits every 3-6 months in the first 2 years and every 6 to 12 months in years 3 and 5. Follow-up FDG PET, we know FDG uptake, it indicates a complete metabolic response and the consequently reduced risk of recurrence and excellent survival. Reduced FDG avidity indicates a partial metabolic response and thus a moderately high risk of recurrence and poor survival. Finally, unchanged or new areas of FDG uptake indicates persistent or progressive disease. As we see in this case that cervical cancer shows high uptake, also the right external iliac node shows uptake, and this patient has a stage 3C due to this lymph node. After therapy, there is no uptake in the cervix. It is like the background, also no uptake in the lymph node representing complete response. Another case with the cancer cervix shows uptake, also parametrial invasion and urinary bladder invasion is noted. After therapy, the cervical cancer decrease in size, decrease in SUV, but it's still showing uptake, so it is a partial response. Another case with the cancer cervix is seen here, taking uptake, and in the left pelvic node, a small para-aortic node is also noted. After therapy, it is progressed with uptake seen in the liver, in the lung, in the mediastinum, and in the left para-aortic region. Radiation therapy planning. PET staging altered management and either by extension of the radiation field to include the para-aortic area or by a change in the total administered dose to be involved nodes in the pelvic area. Nirani et al. Conducted a study to determine whether the use of FDG PET-CT or MRI could obviate surgical staging in radiotherapy planning for patients with locally advanced cervical carcinoma. They found that FDG PET-CT can obviate surgery or lymph node sampling, but MRI couldn't obviate nodal staging and lymph node sampling. Radiation therapy, as we see here, the tumor taking uptake. Also, it is infiltrates the uterus and the upper vagina. In the red color here is the gross tumor volume. Also, the radiation in the green, clinical tumor volume, where it involves the bilateral iliac nodes and the right para-aortic node. PET MRI. The successful integration of PET and MRI enabled the tumor evaluation and staging in a one-stop approach. So it is very nice technique. As we see here, the cancer cervix invading the upper part of the vagina. Also, it shows diffusion restriction, parametrial invasion, and it shows uptake, high uptake in FDG. So this Figo stage is 2B due to parametrial invasion. It is taken T2BN0M0. Another case where the cervical cancer here shows a high uptake, also shows diffusion restriction. Another small node in the right external iliac region that shows uptake. By MRI, I couldn't detect it as a malignant node, but it takes uptake in PET. Also another small lymph node in the aortocaval region, and another small node in the left supraclavicular region. So the stage here is 4B. And T2PN1M1 according to this PET MRI. PET MRI can predict response following radiotherapy. As we see here, the pre-treatment, the tumor take uptake, and this post-contrast, and this is the diffusion. 2 weeks after treatment, the tumor decreases in size and decreases in as uptake by SUV max. Also, it increases in the EDC value. After 5 weeks, it's become very small, taking a small uptake and increase in the EDC value, as we see. Follow-up after surgery. In this case, the patient underwent total abdominal hysterectomy and bilateral salpingioophorectomy, and her MRI reveals this mass in the left aspect of the vaginal wall. It shows intermediate signal in T2. It shows post-contrast enhancement and diffusion restrictions and uptake by PET. So it is a recurrent lesion. Many research work are done to compare the diagnostic performance of FDG PET MRI versus PET-CT. And they found that PET MRI is superior diagnostic interpretation and identified 4 out of 6 tumors not identified in PET-CT. Another study to compare the PET-CT and PET-MRI in lymph node staging, they found no difference in nodal staging between PET-MRI and PET-CT. Another study to compare the efficiency of PET-MRI and MRI alone, they found that PET-MRI is higher in detection than MRI alone in the deep stromal invasion and parametrial invasion and also in recurrent lesions. To identify another study, the role of PET-MRI in predicting tumor treatment response, they found that it can differentiate between responders and non-responders. Conclusion, imaging plays a major role in treatment planning and a prognostic indicator in patients with cervical cancer. Role of MRI is initial local staging, response monitoring and evaluation of disease recurrence. Whole body FDG PET-CT and better than it, the PET-MRI are used for staging locally advanced cervical cancer. They play an important role in detection of lymph nodes and distant metastasis. It can also be used in response monitoring and evaluation of disease recurrence. Thank you.
مساء الخير. شكرا دكتورة أسماء، البرزنتيشن كويس قوي وأون تايم. أحب أشكر كمان الأستاذ الدكتور محمد أبو الهدى على المؤتمر الجميل ده، والسنة ورا سنة حاجة مشرفة. وطبعا